Welcome back to the deep dive. We are uh, tackling an incredibly dense stack of source material today, all focused on the world of non-inflammatory intestinal disorders. These are the acute crises and chronic problems where mechanical issues or maybe genetics or function failure just shut down the GI tract.
That's right. And our mission today is really pure synthesis. We're cutting straight to the critical knowledge, the pathophysiology, the risk factors, and the nursing interventions you absolutely must know.
Right.
Everything we cover falls under that key concept of impaired elimination, which, it cascades into major issues with nutrition, pain, and some really severe fluid and electrolyte imbalances.
And leading that charge, our primary focus is going to be that life-threatening condition that literally stops the flow cold, intestinal obstruction.
Okay, so when we talk about obstruction, we're really looking at two radically different mechanisms, but they lead to the same critical outcome, right? What are the key characteristics that kind of separate mechanical from non-mechanical obstruction? Yeah, that distinction is absolutely critical for treatment. A mechanical obstruction means there is a physical roadblock. You can sort of point to it.
Yeah.
Maybe surgical adhesions from an old surgery, perhaps a tumor pushing inward, or these dynamic internal problems like intussusception.
Where the bowel telescopes into itself.
Exactly, yeah. Or volvulus, where it twists up like a knot. It's a physical thing.
And then the less obvious type, the non-mechanical obstruction or paralytic ileus.
Yeah.
That's where the road itself is okay, but it's just paralyzed.
Precisely. There's no physical block there, but the peristalsis, that smooth muscle movement, it's decreased or just absent, usually because of some neuromuscular disturbance.
Okay.
This is incredibly common after abdominal surgery. We call that postoperative ileus, or POI, or sometimes it's caused by a severe electrolyte problem like low potassium, hypokalemia.
But, okay, so regardless of whether it's a twist or paralysis, the cascade of events is the same and, frankly, terrifying. The contents, air, fluid, food, they start backing up. What's the immediate effect of that buildup on the patient's whole system?
Well, it creates this massive fluid shift. The accumulating contents cause extreme abdominal distension,
Right.
and the pressure builds, which leads to swelling, edema in the bowel wall itself, and then plasma starts leaking out of the capillaries and third spacing into the peritoneal cavity. Yeah, and this rapid loss of fluid from the circulating blood volume is what really drives the patient towards hypovolemic shock and severe dehydration. It happens fast.
Okay, now here's a critical diagnostic point for you listening. The location of the block gives us a clue about the patient's acid-base balance. What should we be looking for there?
Think geographically, sort of. If the obstruction is high up in the small intestine, the patient is going to be vomiting profusely, losing massive amounts of gastric hydrochloric acid.
Okay.
That loss of acid puts them directly at risk for metabolic alkalosis. Now, if the block is lower down in the intestinal tract, you lose alkaline fluids instead, and you run the risk of metabolic acidosis. It's a really crucial geographical diagnostic tool when you're monitoring labs.
And we have to move quickly, I imagine, especially if we suspect the worst-case scenario, which is strangulated obstruction.
Yeah.
What makes that the ultimate red flag?
Yeah, that's when the bowel's own blood supply is completely cut off, compromised. Ischemia sets in almost immediately, leading to tissue death gangrene, potentially within hours.
That fast?
That fast. This segment is essentially dead, putting the patient at massive risk for peritonitis, sepsis, and septic shock. So if the patient's severe abdominal pain suddenly stops and is replaced by just tenderness, or if their pulse and temperature suddenly spike, you have to assume perforation or strangulation. Report it immediately. That's critical.
Okay, so when assessing these patients, obviously history is vital, prior surgeries, cancer history.
Okay.
But let's focus on those classic physical cues. The source mentions syngultus. What is that exactly, and why is it so common?
Syngultus is simply the medical term for hiccups. Yeah, it's thought to be caused by diaphragmatic irritation from all that bowel distension. It's annoying, but common. Much more useful, though, is differentiating between the location of the block, because the symptoms of a small bowel block versus a large bowel block are almost opposites.
Okay, let's break that down then. A quick comparison.
Sure. So if you have a small bowel obstruction, the key features are that mid-abdominal, colicky, cramping pain, and early profuse vomiting.
Okay.
And that vomit can sometimes be really foul-smelling or even described as looking like fecal material because of the backup. The fluid loss is rapid, so severe fluid and electrolyte imbalance is pretty much guaranteed.
Got it.
Now, contrast that with a large bowel obstruction. The contents move much slower there, so vomiting is minimal or might be absent entirely. The cramping is more intermittent and lower down in the abdomen, and they often report obstipation, which is severe constipation, or maybe ribbon-like stools if the block is only partial.
And when we listen with the stethoscope, what are we actually hearing or maybe not hearing?
Well, early on in a mechanical blockage, the body is really fighting it. So you hear these incredibly loud, high-pitched, rushing sounds just proximal to the obstruction. Medically, we call these borborygmi.
Borborygmi.
Yeah, it sounds like this frantic, loud chaos trying to push past that roadblock. But as the condition progresses and the bowel wall starts to fatigue, or if it's a paralytic ileus from the start, those sounds become distant and kind of sluggish and eventually completely absent. Silence.
For diagnostics, then, it sounds like we rely heavily on labs that confirm the dehydration, even if they don't pinpoint the blockage itself. What pattern should we expect to see in those labs?
The lab results really reflect that massive fluid shift we talked about. So you see elevated hemoglobin, hematocrit, and BUN because the fluid component of the blood is leaving the circulation. It's becoming more concentrated.
Right.
Conversely, electrolytes like sodium, chloride, and potassium are often depleted because of the vomiting and that third spacing, the sequestration. So while there's no single definitive lab test, imaging is primary. A CT scan or an MRI will clearly show that characteristic fluid and gas distension in the small intestine, often followed by a complete absence of gas in the colon, which really confirms the small bowel block.
Okay, so non-surgical care. It starts with NPO status, nothing by mouth, and managing the nasogastric tube, the NGT. Getting this right sounds like a major safety challenge. What's the single biggest procedural difference that impacts patient safety when we're dealing with the two main types of NGTs?
The biggest difference, really, is the presence or absence of a vent. The gold standard tube is the Salem sump tube. It has that small pigtail vent.
Right, I've seen those.
Yeah, and because air can flow freely through that vent, it can be connected to low continuous suction safely. If, however, a Levin tube is used, which lacks that vent, you run the risk of sucking the stomach or intestinal mucosa right into the tube tip and causing damage, injury. Yeah. Therefore, the Levin tube must only be attached to low intermittent suction, that little vent hole difference. It's everything for safety.
Okay, so beyond the initial setup with the right suction, what's the ongoing nursing priority with the NGT?
Patency and placement. They absolutely must be assessed every 4 hours at a minimum. You also need to maintain the patient in a semi-Fowler position, kind of sitting up, to aid decompression. And because they are NPO, frequent, really meticulous mouth and nares care is essential for comfort and preventing complications.
And given the severe fluid loss and the NPO status, I assume aggressive high-V fluid replacement is mandatory.
Absolutely. We often start with, say, 2 to 4 liters of an isotonic solution like normal saline or lactated ringers. Frequently we'll add potassium, depending on those lab results.
Okay.
And here's the vital clinical point to remember. Even when you're meticulously monitoring input and output, the daily weight is the most reliable indicator of fluid balance.
Really, more than I know.
Yes, because it's the only true measure of that third spacing, that fluid leaking into the peritoneal cavity that intake and output charts or even labs might miss initially. Weight tells the tale.
Good point. Let's touch briefly on the pharmacology here.
Right.
We have specific drugs for specific causes.
We do. If a patient has postoperative ileus, or POI, drugs like elvamopan might be used. It briefly blocks opioid receptors in the gut to help speed up GI recovery. For partial mechanical obstructions or maybe a functional ileus, metoclopramide is a prokinetic agent. It stimulates motility.
Okay.
And crucially, if strangulation is suspected, which is always a surgical emergency, IV broad-spectrum antibiotics need to be started immediately while prepping for surgery.
And finally, the surgical approach itself. It sounds like the choice between open surgery, the exploratory laparotomy versus minimally invasive surgery, or MIS, has a huge postoperative impact on the patient experience.
Oh, it absolutely does. While the open approach means a larger incision, definitely a longer hospital stay, and usually requires that NGT post-op until the gut wakes up, MIS via laparoscopy is really the preferred technique today whenever possible. Because it translates to short hospital stays, often just a day or two, much less pain for the patient, and significantly, these patients frequently do not need a postoperative NGT at all. Big difference in recovery.
Okay, so we just discussed the acute blockage of obstruction, but often the cause of that blockage might be a more insidious chronic issue, which brings us nicely to colorectal cancer, or CRC. It's the third most common adult malignancy.
Yeah, and the risk factors are really strongly weighted toward genetics and lifestyle. Age over 50 is primary, of course. But certain genetic syndromes are high alert risks. Familial adenomatous polyposis, FAP, and Lynch syndrome, they dramatically raise the lifetime risk. And coupled with that, you have lifestyle factors like a high-fat, low-fiber diet, long-term smoking, and obesity that definitely increase susceptibility.
That really makes screening and health promotion critical then. The American Cancer Society now recommends screening start at age 45 for average-risk individuals. That's changed recently.
That's right. And patients have options they need to understand. There's the annual fecal immunochemical test, or FIT, or the gold standard, which is still a colonoscopy every 10 years.
Okay.
And if they choose the stool test, the FIT test, they must be taught to avoid certain things beforehand. Aspirin, red meat, some vitamins, to prevent getting a false positive reading. Important education piece there.
Clinically, it's fascinating how the location of the tumor completely changes the patient's symptom profile. That seems like a great clue for us.
It really is. It's kind of the difference between a slow bleed and an acute obstruction. So right-sided tumors often grow quite large because the stool is still liquid over there. They tend to ulcerate and bleed occultly, meaning hidden blood. The patient might just develop unexplained anemia and fatigue.
Subtle signs.
Very subtle. Whereas left-sided or rectal tumors, they're found where the stool is more formed, so they tend to cause symptoms of obstruction earlier. Cramping, gas pain, maybe a narrowing of the stool caliber, and often visible red blood, which we call hematochezia. Much more obvious.
Diagnosis relies heavily on imaging, like colonoscopy, but we also monitor the carcinoembryonic antigen, or CEA. What exactly is the role of CEA in CRC?
Yeah, CEA isn't really a definitive diagnostic tool on its own. It can be elevated in smokers or with other conditions too. Its true value is in monitoring response to treatment and surveillance. So if a patient is successfully treated for CRC, their CEA level should drop significantly. If it starts to climb again later on, that's a strong indication of disease recurrence, making it absolutely essential for post-treatment follow-up.
Got it. Surgical removal is the primary treatment, and many patients unfortunately require a colostomy. Let's make sure we hit the crucial safety priority for stoma management.
Yes, this is definitely a top-tier safety alert. You need to assess that stoma for viability. It should look reddish pink and moist. You must immediately report any sign of ischemia or necrosis.
What does that look like?
That means reporting if the stoma appears dark red, purplish, or even black, or if it looks dry or excessively pale. Any of those are red flags. And also remember the stool consistency rule. You expect liquid stool from an ascending colonostomy, more pasty stool from a transverse, and more solid, formed stool from a descending colostomy. Location matters.
Okay, shifting gears a bit now to chronic functional disorders. Irritable bowel syndrome, or IBS, often called the spastic colon or nervous colon. It's defined by painful, often unpredictable elimination patterns, right?
Exactly. And triggers are a huge part of managing IBS. Patients really need to identify what sets off their symptoms. Caffeine, carbonated drinks, dairy products, and definitely stress are very common culprits.
Makes sense.
So management centers around diet specifically, increasing dietary fiber intake to maybe 30 to 40 grams a day, and then using targeted drug therapy based on whether their dominant symptom is diarrhea or constipation.
Can you walk us through that targeted drug therapy, especially focusing on that major safety caution mentioned in the source?
Sure. For IBS with constipation, IBS-C, we use agents like linaclotide or lubiprostone, which help increase fluid secretion into the bowel. For IBS with diarrhea, IBS-D, we might use a specific antibiotic like rifaximin, or for really severe cases in women who haven't responded to other treatments, there's a drug called elostron.
And that's the one with the caution.
That's the one. This is where the major safety caution lies. Elostron carries a potentially life-threatening risk of developing ischemic colitis, basically, reduced blood flow to the colon.
Oh, wow.
Yeah, so the patient must understand they have to stop the drug immediately and report any symptoms like bloody diarrhea or increasing abdominal pain. This is absolutely non-negotiable patient safety education if they're prescribed elostron.
Okay, very important. Let's move to structural issues now with herniation. That's where a weakness in the abdominal wall allows tissue to bulge out. We classify these based on whether they can be pushed back in, correct?
Yes, exactly. We talk about them being reducible, irreducible, or the most dangerous strangulated. An irreducible or incarcerated hernia is one that cannot be pushed back in. It requires immediate surgical consultation because of the high risk of obstruction.
Right.
But the strangulated hernia is the true emergency. That means the blood supply to that tract tissue is completely cut off, leading immediately to ischemia, necrosis, and potentially life-threatening sepsis. Need surgery now.
If a patient undergoes a hernia repair, specifically, let's say, a minimally invasive inguinal hernia repair, MIIHR, what's the one post-op instruction we really have to stress repeatedly?
Best practice dictates they absolutely must avoid coughing because that puts massive strain on the repair site.
Makes sense.
Deep breathing and ambulation are encouraged, but definitely no heavy lifting or straining for several weeks. And crucially, for male patients after inguinal hernia repair, encourage them to stand up to void the first time after surgery. That position helps them empty the bladder more completely and prevents urinary retention, which can be a common issue.
Good practical tip. Okay, finally, let's wrap up with hemorrhoids, those swollen veins caused by pressure down there.
Yeah, usually caused by increased intra-abdominal pressure from things like chronic constipation, straining during bowel movements, obesity, or pregnancy. Initial management is typically conservative, high-fiber diet, lots of fluids, sitz baths for comfort, and maybe some topical anesthetic or steroid creams.
And if surgery, like a hemorrhoidectomy, becomes necessary, there's a painful but really critical safety alert regarding the first post-operative bowel movement. What's that about?
Yes, patients need to be warned that the first bowel movement after surgery can be extremely painful. And that intense pain, combined with straining, can sometimes trigger a vasovagal response, meaning they might feel suddenly lightheaded, sweaty, nauseous, or even experience syncope, which is fainting.
Oh my goodness.
Yeah. Therefore, stool softeners are not optional. They are a mandatory intervention prescribed both before and after the procedure. The goal is to soften the stool significantly to mitigate the pain and reduce the risk of that vasovagal fainting episode. Safety first.
Yeah.
#Otro.
Wow, this was definitely a rapid, but I think really thorough deep dive into the essentials of these non-inflammatory intestinal disorders. From that sudden crisis of obstruction, where the type dictates the acid-base problem, to the chronic management of CRC, IBS, hernias, and hemorrhoids, we really saw how often impaired elimination drives total body compromise.
Absolutely. And the essential nursing thread that runs through all these conditions is that focus on meticulous monitoring and GT care, those daily waits for fluid and electrolyte balance, aggressive pain management, and crucially, recognizing those immediate signs of danger, like strangulation, perforation, or ischemic colitis. Vigilance is key.
If we step back and kind of connect all of this, from the physical twists of a volvulus to the functional spasms of IBS, what really stands out to me is just how complex and sensitive that gut-brain axis truly is. The way chronic stress can exacerbate something like IBS, or how simple dietary fiber influences potentially deadly conditions like CRC or complications from hemorrhoids. It just highlights how integrated elimination is with our overall health and wellness, doesn't it?
It really does. It's all connected.
Well, thank you for taking this deep dive into the source material with us today.
Thank you. It was a good discussion.